This morning I hope to cover some new treatments in cholesterol lowering and fashion that around three separate cases. The first one highlights the use of non-statin therapy. The second is a patient with elevated lipoprotein A, which seems to be coming up very frequently in the clinics. And then something a little less common but very important with a lot of pharmacologic development, severe hypertriglyceridemia. The Heart Institute is involved, and some of these trials will be discussed during the talk in lipoprotein A lowering trials, PCSK9 trials, and another PCSK9 we'll talk about, inclisiran. So here's our first case. It's a 55-year-old male with atherosclerotic heart disease and at a very young age had bypass grafting, has also had subsequent PCI and a long-standing history of hyperlipidemia. And possibly one of the reasons he's continued to have events is that he's been referred to the clinic for statin intolerance. His dad had bypass grafting at a young age as well, and he had high cholesterol. The patient has a history of gout, and he didn't tolerate Lipitor due to myalgias, but he is on rosuvastatin 20 and Zetia 10. In discussing some of the new therapies, he did report a, quote, fear of needles. And if you look back, and this is important to do in these kind of patients, look back at their baseline LDL years ago was 195 prior to treatment. So hopefully you can recognize this is a patient with familial hypercholesterolemia, and we had a grand rounds about this, excellent grand rounds, a few weeks back. How do we approach this patient who has the following lipid profile? So he's not at goal, his total cholesterol is 191, his lifestyle metrics are in good order, his HDL is 50, he exercises, his triglycerides are well controlled, but his LDL is 120. He did get a 41% reduction from baseline. So you probably are familiar with some of the new therapies that we have to address this kind of patient: bempedoic acid, Repatha, Praluent, and inclisiran. And we'll talk about some of the advantages and disadvantages of each of those and where you might consider those. And so actually the next step in preventive evaluation is not just focusing on cholesterol, although that's what I'm going to do in the talk, but it's looking at lifestyle metrics. And this is some recent data that came out where they assigned a score of 100, and you got a score of 100 if you filled the Essential 8 metric. And Essential 8 is the same as the Simple 7, but it includes a sleep component. And what are the metrics to get a score of 100? Sleep, 7 to 9 hours, so hopefully everybody got that last night. Not smoking. The blood pressure goals now are quite low, 120, less than 120 over 80. The 5 components of diet: fruits and vegetables, fish weekly, fiber-rich whole grains in your diet, low sodium and low sugar diet. And then at least, this is an or situation, at least 150 minutes of moderate activity per week or 75 minutes of vigorous activity. A fasting blood sugar less than 100 and an A1C less than 5.6, and his BMI is close to 25 as you can get. And if you fill those metrics, it has a significant impact on your longevity, your all-cause mortality, and your cardiovascular mortality. So that's our initial approach. This patient, those metrics were well identified and taken care of, and it wasn't his problem. And that is typical for familial hypercholesterolemia, somebody who has a very high LDL that you're almost surprised to see it. And so this is a busy slide that I'm going to come back to at the end of the talk, but it points out all of the development in pharmacogenetics that have been occurring centered around the liver in trying to manipulate, inhibit, and regulate cholesterol metabolism. And hopefully, it's very dizzying and confusing right now, but hopefully at the end, we'll be able to come back to it and make a little bit of sense of it. And so for our patient, what is the patient's goal? And hopefully you recognize that this patient's LDL goal is less than 55, the old goal being less than 70. We'll talk about maybe why that got dropped to 55. This patient is very high risk, has had major cardiovascular events, has associated high-risk conditions with familial hypercholesterolemia. So we should be aiming for 55 or less in this patient. And here's some guidelines. These are the multi-society guidelines from 2018 that are going to be updated soon, telling us how we can get there. So they're not completely up to date, but they do say that after adding Zetia as an initial step, if the LDL is above 70, we consider PCSK9 therapy. And The data surrounding statin therapy is pretty well known that for every 38 milligrams per deciliter reduction in LDL, we're seeing a 27% reduction in MI and also all-cause mortality. So the statins remain sort of the mainstay of lipid-lowering therapy. And they do a very good job. In high-intensity statin therapy, we can expect a 50% reduction from baseline LDL with atorvastatin 80 or rosuvastatin 40. But we don't get there. And this kind of information is consistent at Alina and across multiple organizations. But here's the NANES data through 2020, patients with coronary disease. You can see in dark here, of those receiving a statin, 60+% of them still have an LDL above 70, 80+% of them still have an LDL above 55. And the use, even though it had been out for many years, of even Zetia in this group was extremely low. So what are the challenges and why do we have data like that? Well, the paper suggested that the factors contributing to these low rates of attaining goals include inadequate statin intensification, so we don't titrate up the dose, we sort of forget about it, insufficient add-on therapy like Zetia, low use of novel therapies, and we're going to talk about what the novel therapies are, and low rates of statin use, and then interesting term, intensification may be related to prescriber or patient hesitation, right? And there's a lot of media that can work against us with some of these conventional drugs because the side effects or the potential side effects maybe get overplayed in the media compared to their benefits. This is probably one of the number one reasons, though, is statin intolerance is a real entity. It's interesting that if you look at the reported incidence, it's actually lower in clinical trials, around 5–6%, but then in clinical practice up to 25%. It's important to recognize that that can be partial or complete, and our patient was a partial statin intolerant, tolerating some dose. As you go up in the dose, was having issues. It may be real or perceived, and that's an important distinction. As you're going through these types of patients, it's important to document that at least 2 statins were tried, including a hydrophilic statin. And the hydrophilic statin would be rosuvastatin or pravastatin. Those medications need to be documented before you're going to apply for more advanced therapy because they are more costly. And then you should look for modifiable factors. Everybody that comes to the statin intolerant kind of new preventive visit gets a TSH. We ask about alcohol use. We look for vitamin D deficiency. We know that low vitamin D leads to higher incidence of statin intolerance. We had a fellow here that was exercising extremely high, was on atorvastatin and got full-blown rhabdomyolysis. So in my exercising and my really aggressive people, I make sure they drink before, during, and after exercise. And then look for these common drug interactions. Gemfibrocil is one that should never be combined with a statin. The protease inhibitors in the HEIV group, amiodarone commonly used for AFib, some of the antifungals, immunosuppressants, and then colchicine. So we need to kind of look for these. And the ACC now has a tool that helps guide us through some of the issues with statin intolerance and gives some suggestions around alternative plans. So that's one issue. And the other one I think is in the media quite a bit is the concern about diabetes. And sure enough, when you do a meta-analysis on the cholesterol treatment trial list data, there is about an 8% higher risk of proceeding to diabetes with an elevated A1C in those populations. So there is an effect between statins and glucose tolerance. So what, as a result, and this highlights some new approaches to the old medications. I know Dr. Meadham is a big fan of this. He's texted me about this. And there's a couple of newer approaches that instead of going straight to high-intensity statin therapy, we start with moderate-intensity statin therapy and add Zetia. And by doing so, in this data set, in this population, they actually had a better LDL at 3 years, a lower LDL, more patients achieving an LDL of less than 70, less discontinuation of the drug, and actually a slightly lower event rate in this group with the combination program. And then in the diabetes literature, with no difference in endpoints between the moderate intensity plus Zetia, less diabetes. So some of the newer approaches that you can think about in some of the patients where there's concern about an elevated A1C, there's concern about statin intolerance. Our first line add-on therapy in the guideline was Zetia. And how does Zetia work? Zetia works in the jejunum, so it works at the gut level to inhibit the Niemann-Pick C1-like receptor. It inhibits the absorption of chylomicron and chylomicron remnants and thereby increases the LDL receptor density and drops LDL. And it works. This is an old trial that you've probably seen, Improve-It trial. Patients with acute coronary syndromes, Zetia was added to their simvastatin, and they got a 22% reduction in LDL, and then over a 6-year period, a 6% lower MACE. It's one of the first trials to really support the lower is better kind of hypothesis. And that brings us to the medications of PCSK9 inhibition. These have been out, the monoclonals have been out since 2015. And the reason I show you the power injector here is that our patient had a fear of needles. You don't see a needle with this treatment. So this is held up against the skin at either the abdomen or the thigh level. The injection takes 5 seconds, and you don't really see the needle, so you don't have to worry about patients that say, I can't handle needles. You're not looking at them like the old insulin type therapy. And how do they work? Well, PCSK9 turns out to be, this little red PCSK9 turns out to be a protein modulator that degrades the LDL receptor normally in the hepatocyte. And by inhibiting that PCSK9 with our monoclonal antibody, we can upregulate the LDL receptors and then sort of naturally promote the removal of LDL by the LDL receptor by the liver. So the LDL levels drop dramatically by promoting this LDL receptor recycling. These are the 2 big trials with the 2 clinically available medications in monoclonal therapy, evolocumab and alirocumab, Repatha or Praluent. The 4-year trial, the Odyssey outcome trial, these are very big studies that have been looked at for several years now, but they show consistent LDL lowering in both trials of nearly 60% in patients with atherosclerotic heart disease on maximally tolerated statin therapy. So an additional almost 60% LDL reduction. And then from an outcome perspective, the curves start to diverge as early as 6 months, and by 36 months or 4 years, we have a substantial 15% reduction in the primary endpoint, MACE, primary endpoint of composite endpoints listed below here, with a very reasonable number needed to treat in both studies, around 50. Looking at more high-risk patients within the 4-year study, those with an MI within 1 year, even more prominent MACE reduction of 25%. So these medications work very well. And going back to that target of 55 versus 70, there's a few reasons that I think that switch was made. One is if you look at the actual plaque, so this is intracoronary plaque going into the heart vessels over an 18-month period. When you add Repatha to patients on maximally tolerated statin therapy, it's called the Glagov trial. And you can see that as you get down below 55, most patients, there's a negative number in atheroma volume change. Most patients are going to get regression of their plaque. So it can actually, the calcium doesn't go away, your calcium score doesn't go down, but the soft plaque gets taken out of the system. And a little bit less so at 70. There may be still people that are progressing at 70. And the clinical data supports that. So the clinical data, sort of this curve of what's happening in the vessel, looks a lot like what's happening to the clinical events. They look fairly similar. Here's 8-year follow-up of the 4-year trial that has come out in 2022. And one of the concerns is the patients who got extremely low LDLs, how did they do? And there were no increased adverse events in this very low LDL group, just continued reduction in cardiovascular events. So it really, again, supports this lower is better in patients with atherosclerotic heart disease. So the highlights, these medications are removed in the serum by proteolysis. So they're not going through the kidney, they're not going through the liver. You don't have to make adjustments for kidney or liver disease. They don't get into the muscles, you don't have myalgias. Neurocognitive effects were studied in the Ebbinghaus trial, and it was negative for any neurocognitive adverse events. The adverse events were similar to placebo in that 8-year follow-up trial, up to 8 years. The self-injections are actually very well tolerated. I was a bit surprised when they came down at how well these are tolerated and how much patients actually kind of like it. They do report occasional injection site reactions, and moving them around is helpful. Unlike the statins, there's no associated with an increase in A1C, and as a bonus, it lowers one of the best treatments we have right now, but we'll talk more about that, in lowering LPA of 27%. And then bempedoic acid. This wasn't in the guidelines because it's a newer medication, but it's a very interesting mechanism. It's pretty exciting how it works. This works in the step right upstream from our statins. Statins inhibit HMG-CoA, and ATP citrate lyase is right above that, and in a similar mechanism, it increases LDL receptor density and reduces LDL. Now, what's interesting about bempedoic acid is it doesn't get activated until it's in the liver. It's a prodrug. So there's no enzyme conversion in the skeletal muscle, and this medication has been studied in statin-intolerant patients and has done very well. It works as an add-on therapy in both low and high-intensity statin therapy, reducing LDL around the 20% range, and then it comes in a combination drug with Zetia called Nexlizet, where compared to baseline, a 36% reduction, compared to placebo, a 38% reduction in LDL. And then most recently, New England Journal, just last year, the actual outcomes trial for the study came out, and it lowered LDL by 21%. And here's another nuance to these medications. This medication has an anti-inflammatory component. It significantly reduces highly sensitive CRP. We know that inflammation plays a role in atherosclerosis. So you got a 22% reduction in CRP and a nice 13% reduction in MACE at 60 months. And importantly, they also included primary prevention patients in this trial. They weren't just secondary prevention patients like we saw in some of the PCSK9 trials, and it had a significant reduction of events in primary prevention. So a statin-intolerant patient with atherosclerotic heart disease, without atherosclerotic heart disease, looks to be effective. Probably the biggest side effect to be concerned about is it has an impairment of uric acid absorption at the kidney level, and there's an increase in hyperuricemia, and clinical gout was only 1%, but remember, our patient had a history of gout. This would not be a good medication for him. So we didn't add bempedoic acid because of the history of gout, and also the magnitude of LDL reduction. Remember, the LDL was still pretty high, and we needed more than a 20 or 30% reduction. We really needed more of that 50, 60% reduction. So we went ahead and added Repatha, and after 6 months of therapy, his LDL was under control. We thought we had everything under control, and we were happy until he called back 9 months later and said, you know, these injections are starting to itch and bother me a bit. Is there anything else out there that might be available where this is, I have to inject myself less frequently? So, well, actually there is. And this mechanism, the name of the medication is inclisiran. You've probably heard about it, but this mechanism is very important to kind of understand, because if you look at the new treatments that are coming down the pipeline that are soon to be approved, a lot of them are using RNA interference. And this is one of the mechanisms of RNA interference. It's called siRNA. And just to sort of walk you through it, it's a double-stranded RNA that targets a RISC complex, and one of those strands combines with the RISC complex, and that complex is toxic and cleaves the messenger RNA to the PCSK9 protein. And you can target any RNA, and a lot of the drugs are doing that. And the interesting thing is that this RISC complex RNA stays in the hepatocyte for a long time and continues to cleave that messenger RNA. So these are long-acting medications. Inclisiran is delivered once you do your initial injection every 6 months, so just twice a year. And you get the same inhibition of PCSK9 and upregulation of the LDL receptor as you do with the monoclonal. And the Orion studies are the ones that really have looked at inclisiran. And the initial dose is given at 3 months post the first and then every 6 months thereafter. Here, compared to placebo, a 54% reduction in LDL over time compared to baseline 50%. So maybe not quite as much as the monoclonals, but very close. No increase in adverse events compared to placebo other than the infrequent injection reaction. Now, the outcome study is not out. It's called Orion 4, but they did do exploratory endpoints on adverse events in Orion 11, and there is a significant looking trend here of a 20-25% reduction in events, but we await sort of the Orion 4 to see a little bit more detail about that. Here's a study called Inclisiran First, where they actually gave inclisiran up front compared to usual care, and you can see they were able to control LDL much better compared to usual care, which is dealing with the issues we mentioned, statin intolerance and others, and getting no increase in really adverse events and no safety events, getting 76% of the patients down to this less than 55 goal in patients with atherosclerotic heart disease. That was called the Victorian Initiate trial. The inclisiran trial are Victorian, and here are the ones that you're going to hear about coming down the pipeline. Victorian 1, Victorian 2, and then Orion 4 is the big one with atherosclerotic heart disease, evaluating long-term effects in cardiovascular outcomes. Victorian exception we are participating in here at the foundation, and that's comparing, it's similar to that Initiate trial in that we're offering patients inclisiran versus usual care with a recent hospitalization for ACS to see if you can get patients to the LDL goal. So in summary, inclisiran has advantages of this 6-month dosing. It improves adherence. If you only have to do something once or twice a year, you don't have to think about it. Now, it does also lower lipoprotein(a) like the monoclonals, has no effect on the A1C in the muscles, but this needs to be administered either in the clinic or the hospital setting, and our pharmacy works with us to get these sites approved and able to do that. The infusion center here was doing it, and now we're actually doing it in the clinic. We're awaiting the outcome data, although the exploratory endpoints look favorable on this. So kind of summarizing the non-statin therapy, Zetia is going to be our first line. It's been around a long time. It has decent but modest LDL lowering and modest event reduction of 6% at 7 years. Really no reason to not add this fairly early on, potentially even before getting to high-intensity statin therapy in order to avoid some of those issues. Bempedoic acid is a good alternative for statin-intolerant patients that need moderate LDL lowering. It lowers CRP and inflammation. We want to avoid it with gout, as monotherapy and in combination can lower LDL and has that 13% reduction in events at 5 years. The PCSK9s then are the monoclonals, Repatha and Praluent, lowering LDL, and then inclisiran. We're awaiting that outcome data, Orion 4. Now there's, just to finish off, other LDL, you might think, well, what about, the other ones I've heard about? The Welchol, Cholested, Questrans, those have been around since the 70s and 80s. These medications aren't very well tolerated. Most people will get side effects, GI side effects, bloating. It also exacerbates triglycerides in a patient with a baseline hypertriglyceridemia. Doesn't have any outcome data. They never really did the outcome studies. It is the only medication safe in pregnancy, though. So if you need dramatic LDL lowering in pregnancy, this would be the one medication you can use. And then some other ones that I'm not going to go into detail because they're really specifically designed for the patient with homozygous FH. These are severe hyperlipidemia patients with baseline LDLs above 400. A lot of them are in a REMS program or a registry where you have to sign up and certify. But Kynamro or Mipomycin, Lomidopide, and even Acumab is the newest one. Those patients are probably best referred to a lipid specialty clinic to work on getting these. They're very expensive and somewhat difficult to achieve. So that's sort of our non-statin patient. Let's move on to another scenario that we get a lot in the clinic, and that is my LPA is high. So here's a asymptomatic 65-year-old female who was at her doctor's office, and they decided to draw an LPA, and it was found to be 270 nanomoles per liter. And that caused concern, so she came to the clinic. She's very active, exercises, never smoked. She's hesitant to take drugs, has heard about, all the bad things about statin, really is concerned about that. Has a hyperlipidemia, modest hyperlipidemia with an LDL of 137, and said, well, what should I do? And what does this LPA mean? What sense can we make of that? And here is LPA, and what's interesting is it's an LDL with an ApoB particle, a divalent bond, this repeating, called Kringle or repeating protein sequence on top. That's the lipoprotein A, is this part, and here's the LDL. And it's this specifically in yellow here, it's the repeating Kringle 4 type 2 that determines your LDL level and your, LPA level. Your LPA level is the size and the variable number of these. It can be very long, it can be very short, and that will determine your LPA. And that's genetically determined. You can't really influence that with lifestyle. So you get an LPA Kringle 4 type 2, and that's what you've got. And that's created some issues with how we measure this. So you've probably seen, we used to commonly see the milligrams per deciliter measurement, and now the more commonly measuring nanomoles. Well, the nanomoles is really measuring particle number, kind of like LDLP versus LDLC. And so here's a patient on the left that has, the repeating Kringles are much longer here. They're milligrams per deciliter. The amount of lipoprotein A is higher, but their nanomoles are the same. They have the same number of particles. And then over here, more particles over here, so the nanomoles per liter are higher, but because the particles are bigger, the milligram per deciliter are the same, and they equal out to the higher particles over here. Which one's better? Most of the assays have gone to the nanomole per liter, and it looks like the risk is probably better captured, much like LDLP versus LDLC with the number of particles, but certainly there's more data needed in that regard. But it explains the assay. But why is LPA so bad? It has a triple threat here. So you have a promotion of atherosclerosis, promotion of the foam cell, and promotion of inflammation. You have homology to plasminogen with lipoprotein A, so you have thrombosis. It binds to fibrin. And then, interestingly, there's been association with progression of aortic stenosis. And there is a trial that we were involved with, and it's looking at inhibiting LPA with some of the new medications I'm going to show you in trying to prevent the progression of aortic stenosis. Once a patient, gets aortic stenosis, there's not much we can offer them to abate the progression to severe aortic stenosis, and looking at whether LPA can play a role in that, because it does play a role in the damaging of the endothelium and promotion of calcification of that valve. It's also autosomal dominant. So, if our patient's mom probably had it, although back then they weren't measuring it, she has it, she could pass it on to her children. It's also been termed the most prevalent cardiovascular risk factor in the world. 1 in 5 people have an elevated level. You're talking 1.6 billion people with high levels of this lipoprotein A. It's associated with the aortic stenosis progression, and as we discussed, the lifestyle factors, diet, and physical activity really have a limited impact on this. It's genetically determined. And so the guidelines are wrestling with who should get it, and there's some disagreement there. The NLA, the National Lipid Association, does recommend checking it at least once in your lifetime, and everybody can agree over here that if you have a family history of premature atherosclerotic heart disease, this is worth checking. And we certainly want to make sure if somebody comes in the clinic, their parent had an MI in their 40s or 50s, we draw an LPA level so we can understand their risk a little better. Now that risk, interestingly enough, is most important in patients with either clinical or subclinical atherosclerosis. Here is the highest LPA quintile in those with calcium scores of 100. So the risk is higher than in the patient with a calcium score of 0, which makes sense because of all the things it causes if you have underlying atherosclerosis. So Roger Blumenthal and other people have said, well, maybe we should target the LPA testing into those with either subclinical or clinical atherosclerosis, and not everybody, those with calcified aortic valve disease or those with a premature atherosclerotic heart disease. Exactly who to test and when is clearly still being worked out. How do the guidelines handle elevated LPA? So you look here, an LPA of greater than 50 or 125 nanomoles in the primary preventive patient is a risk enhancer. So our patient is kind of in this borderline risk category. If risk enhancers are present, then a discussion regarding moderate intensity therapy. And so what's important about that risk is that risk is somewhat linear. The higher your LPA, the higher your risk. And our patient was right around here at 270, almost a twofold increased risk for atherosclerotic heart disease. Levels above 125 or above 50 are the concerning areas. And how then can you extrapolate back into reducing that risk importantly? So here's some predicted magnitude of risk reduction. We know that a reduction of LDL of 28 milligrams per deciliter or 1 nanomole here results in clinically significant reduction in events. What do we need to do to LPA to get kind of a similar kind of statin risk reduction? Well, turns out you're going to need to drop LPA by 140 to 200 nanomoles per liter. You almost need to get rid of LPA to reduce your risk. So the therapies we have, most of which in the best case scenarios are lowering in the 20 to 30% range, aren't going to have much an effect on the clinical outcome. So nicotinic acid is pretty much not used anymore due to the HPS2 Thrive and other data showing a lack of benefit. These are drugs for, as I mentioned, for homozygous FH. The statins actually increase LPA, and you'll see that if you start a statin, all of a sudden, and you repeat the LPA is higher. The ezetimibe, bile acid sequestrants really don't do much. PCSK9 inhibitors, only this modest decrease. Only lipid apheresis is effective. That's a bit of a bounce, so you do the apheresis and the LDL and the LPA drop, and then by the time people come back 2 weeks later, it's back up. And it's obviously pretty difficult to do and costly. So as a result of this, there's been a lot of interest in developing medications to reduce LPA. We need a much more prominent reduction, and we don't want to send people every 2 weeks to drive down here. And so here's the current state of these emerging therapies, and you've already been probably hearing about it in the literature, but these are coming out. So here's our familiar siRNA mechanism. The most evolved or the furthest along is probably olpasiran, and it's that siRNA that's inhibiting ApoA synthesis by cleaving that messenger RNA. Pelacarsen is another one. That's the one that's studying the aortic stenosis progression. That's ASO, which is antisense oligonucleotide. It's very similar to siRNA, a little bit different. It's single-stranded RNA and not double-stranded RNA, but again is irreversibly binding to the RNA and inhibiting ApoA synthesis. And then an oral direct LPA inhibitor is being developed, and we'll be hearing more about this. I think this is in phase 2 trials. This is a daily oral drug. So kind of to summarize where it's at, the siRNA drugs, olpasiran, every 3 to 6 months. Those are the longer acting ones. Pelacarsen, monthly, the ASO, and then the oral LPA inhibitor given daily. And what do they do? Remember, we need significant LPA reduction to have an effect on the clinical. In this group, 98% of the patients achieved an LPA less than 125. At the highest dose, LPA reductions of over 80% in the pelacarsen and the ASO drug. And then here's the siRNA drug, the olpasiran. Again, 98% of patients achieving less than 125, dramatic reductions up to almost 100% reduction. These trials are the ones I mentioned at the beginning that the Heart Institute and the foundation is involved with. The LPA Horizon trial has closed to enrollment, and we should be hearing this result next year, and that was patients with atherosclerotic heart disease that had an LPA of above 70 milligrams per deciliter. And Ocean A, we are also involved with olpasiran every 3 months in patients with atherosclerotic heart disease and LPAs above 200 nanomoles. Notice milligrams per deciliter in nanomoles. Results, this one's still enrolling, so results are coming out, but you'll start to see these, and once they do, we're going to have to decide who gets that. So in summary, kind of takeaways, it's an independent risk factor. checking it at least once in your lifetime is probably a reasonable idea, particularly if you have a first-degree relative with premature atherosclerotic heart disease and an elevated LPA. Although lifestyle modifications, intensive risk factor modification are important, they won't reduce your LPA levels. And then these emerging therapies are very interesting, and we'll see how they come to light over the next couple of years. So going back to our patient, we did run her through the pooled risk equation, and sure enough, she's kind of intermediate or borderline risk and the 6.1% 10-year risk. And the recommendation is to consider moderate intensity therapy. Your LPA may be playing a role, your LDL is elevated, and she didn't really like that answer. Said, yeah, I'm still not really enthused about taking a statin. Is there anything else you can do to help clarify my risk? And if you go back to that ACC kind of primary prevention guidelines, yes, and if the risk discussion doesn't conclude in initiating therapy, we can go ahead, if the risk remains uncertain, and consider a calcium score in these patients with a 0 score saying, okay, we won't treat you with a statin if you're positive, favoring a statin, particularly if you're above 100 to the 75th percentile, then we're really going to probably feel better about starting the medication. We know your risk is higher than a 0. And that's from the MESA trial that regardless of your age, a calcium score of 100 confers a significant increased risk, and then 300 in blue here being the highest risk category. And importantly, the calcium score of 0, I think I talked about this a few years ago in a grand rounds, having a 5 to 7 year warranty of very low risk. And the guidelines don't perform very well. We know from MESA that a calcium score of 0, 50% of the patients, a statin would be suggested in that group, and 1 in 5 where statins were not recommended having subclinical disease. So it's a nice way of tailoring treatment and answering our patient's question, which is, do I really need this? And we look at the global guidelines regarding coronary calcium, and there's across the world fairly common agreement that intermediate risk patients can benefit in the asymptomatic population, that we can use a 0 to downgrade risk and use a calcium score of 100 to feel confident about initiating statin therapy. The non-agreement points are whether we should recommend aspirin for calcium score or antihypertensive therapy. You have different society guidelines that recommend, for example, the National Lipid Association does recommend beginning aspirin at a calcium score, and so does SECT. And why do they do that? Because the MESA trial shows that the number needed to benefit is below the number needed to harm, and that flip occurs at about a calcium score of 100. So if we have a calcium score above 100, we can feel fairly confident. There's been a lot of discussion about using aspirin in primary prevention. Here's a way of tailoring it specifically to our patient. And then the NLA recommendations, where we develop higher and higher calcium scores. We now lower our LDL goal, consider statin therapy, even non-statin therapy if needed, and add aspirin. So in our patient, we did the calcium score, and surprisingly to everybody, and this happens a lot, the calcium score was actually quite high, 310, probably part of her family history and her elevated lipoprotein A. So we did start a hydrophilic statin and added the baby aspirin. And just as a reminder that seeing your plaque is very motivating, right? So here's old data from Matt Budoff, but as the calcium scores go up, you start to see magnitudes of changes in diet and exercise. And the higher your score, the more motivated you become. So, and then our last case here, how are we doing for time? Our last case here is a patient with recurrent pancreatitis, a young patient who's got atherosclerotic heart disease and has a history of severely elevated triglycerides, is statin intolerant, so is on Repatha, is on fenofibrate, Visipa, and Zetia, but is not obese, not diabetic, not drinking excessively, but has triglycerides of 4,000. So what do we do with a patient like this? If you've ever had a patient with pancreatitis, you know this is an awful syndrome. It's incredibly painful. You're in the hospital for weeks, not eating. this is miserable, and you certainly don't want another one. And so it brings up this spectrum of hypertriglyceridemia, and I'll just sort of end by going through approach to high triglycerides. Modest elevations are defined as 150 to 500, 500 to 855, but when we get into this severe hypertriglyceridemia patients, we need to start thinking of a couple things. One is FCS, and what is FCS? FCS is familial chylomicronemia syndrome. This patient was shown to actually have this, very high triglycerides, and what is it? Well, there's a genetic defect in lipoprotein lipase, and lipoprotein lipase allows us to break down our dietary chylomicrons, and those accumulate, and you end up with chylomicronemia. These are the lipemic blood samples where if you pull them out, there's a white creamy top. They don't respond typically to available treatments. Fenofibrate or Tricor is the main therapy. It works through lipoprotein lipase. So if lipoprotein lipase isn't working, that medication doesn't do well, as evidenced by our patient who's on it and still has triglycerides at 4,000. It's typically not associated with overweight conditions. Genetic testing remains the cornerstone. We did do genetic testing him, and he has a defect in lipoprotein lipase. Now, there are patients with very high triglycerides that don't have FCS. FCS is actually very rare. They have this specific mutation in LPL. They're very high risk for pancreatitis. The secondary risk factors are absent. So this is a more typical patient over here that has uncontrolled diabetes, A1C 10 or 12. They're obese, they're drinking, they're eating a lot of carbohydrates, their triglycerides are 4,000. They have a risk of pancreatitis, but fibrates and lifestyle metrics are going to work better over here than in this patient. And one of the critical things to do in these patients is to limit dietary fat. So as the triglycerides increase, we need to eliminate added sugars, and our total fat should be reduced from 30 to 35% to 10 or 15%, which is incredibly low fat and somewhat difficult to do. Abstaining from alcohol, exercising, it's really been the cornerstone of therapy that we've had to offer these people. Until now, these are the new medications, and these are coming out very soon. And they are ApoC3 inhibitors, and I'll show why ApoC3 inhibition works. But one is a ASO to ApoC3, and one is siRNA, olzarsen and plozasiran. I can't even say some of these. I mean, they're not even out. But one is using the ASO single-stranded method. One is using the double-stranded siRNA method to inhibit the mRNA transcription of ApoC3. And why ApoC3? Well, ApoC3 here, as these chylomicron remnants are presented to the liver, it blocks their removal by the liver. So there's so many of these mechanisms that seem to be counterproductive. But fortunately, science has figured this out and has figured out that if we inhibit ApoC3, we can make the liver take those chylomicrons back up. And what happens to triglycerides if you inhibit ApoC3? Well, here's the ASO, no, I'm sorry, this is the siRNA, because when it says serin, that's usually siRNA, and when it says MAB, that's a monoclonal, kind of giving away their mechanism in the names. So this is the siRNA drug. What happens to ApoC3? It drops to almost zero. You're inhibiting it because you're not making RNA, the RNA can't make any ApoC3. And what happens to your triglycerides? Well, they drop almost 80%. So it's incredibly effective at lowering triglycerides in these types of patients with FCS. And importantly, and both medications have shown this, it reduces recurrent pancreatitis. And reducing even one of these events is thousands of dollars and a month in the hospital. So in the placebo group here, they're going on to continue to have recurrent pancreatitis events. And then in the treated group, pretty much stop that process. So here's kind of the statement of where they're at. Both of these drugs have been fast-tracked by the FDA, and we should be looking at approval very soon, and certainly our patient is very interested in when that's going to become available. They actually have a compassionate use, but we felt like by the time we filled out the forms and got through the process, it's probably going to be clinically available. So we're just waiting for it. I want to say lastly about Vasipa. There's controversy around fish oils, but if you look at a specific group such as patients with atherosclerotic heart disease with triglyceride elevations of 150 or higher, the EPA-only omega-3 fatty acid Vasipa icosapent has very favorable data, and there's some discussion around the way that these trials were performed, but the data is very convincing that it reduces cardiovascular events. So here's a 25% reduction over a 5-year period when Vasipa was added 2 grams twice a day in patients with atherosclerotic heart disease with only modest elevations of LPA, of triglycerides. And then the Evaporate trial were actually kind of similar to Glagov trial, where patients were looked at with intravascular coronary ultrasounds, and there's reduction in fibrofatty and low attenuation plaque. So it has an impact on atherosclerosis. One of the criticisms is they use mineral oil as a placebo in this group, but if you actually look at the mineral oil versus placebo in the Evaporate trial, they weren't much different. So I don't think this can be explained by mineral oil in the placebo group, and I'm actually personally still a fan. If you have elevated triglycerides and atherosclerotic heart disease, you should be on EPA-only omega-3 fatty acids. That's one of the other issues. Some of the trials combine EPA and DHA, which may be affecting the data, but using EPA-only omega-3 FAs, I think, is a good idea. And so summarizing the approach, you have these different levels or categories of triglycerides. Moderate hypertriglyceridemia, it's a risk enhancer. We have to consider intensifying our LDL goal. Look for secondary causes. It's diabetes out of control, thyroid, the use of thiazides, steroids, HIV drugs, retinoids, estrogen, and then begin a reduction in calories from fat to 35%, less than 6% added sugars. Talk about alcohol, exercise. We know that this 150/75 program works. And then in patients with atherosclerotic heart disease, adding EPA-only fish oils. And then as the triglycerides get higher and higher, when the risk of pancreatitis begins at about 500, so now we would consider adding Tricor. And in the severe hypertriglyceridemia patient with a high risk for pancreatitis, these are the kind of patients you might consider an ApoC3 agent when they come out, and referral to the lipid clinic, consider FCS genetic testing, and severely restricting their dietary fat. So the statins remain the mainstay of LDL lowering, and statin intolerance and diabetes is kind of here to stay. I think it's part of the reason that we have suboptimal LDL lowering and underachievement of our goals. And this moderate dose statin plus non-statin therapy is a new strategy. Combining moderate intensity statin with either Zetia or bempedoic acid or other agents is looking like the new approach to reducing some of these issues that we've had to deal with. But there remains a dramatic underutilization of the therapies, and we need to be aware of them and which patient might benefit. And the pipeline of these pharmacogenetic therapies is rapid and prolific. You're going to continue to hear about these coming out, and hopefully the talk will help you, deal with, all these names and what they're doing. And going back to our, very dizzying original slide, hopefully here's the liver. Hopefully you can sort of start to make out some of the things that are in development. Here's bempedoic acid, which is that one step right in front of our HMG-CoA reductase statins. Here's the Niemann-Pick C1-like receptor with Zetia inhibiting the chylomicron, and then our PCSK9 monoclonal body inhibitors inhibiting PCSK9, and inclisiran doing the same thing at the cellular level with siRNA, and then our ApoA mRNA inhibitors, RNA inhibitors, or the direct oral inhibitors are there, so we can, hopefully it's a little less confusing, although it's still a really busy slide. And I would just mention that we have a really good pharmacy and pharmacy liaisons that help us so much with this. I don't think all of these patients need to be referred to the preventive clinic. If you see a patient that you think could qualify, you can certainly touch base with either Allison or Keith, and they'll help guide you through the pre-approval process, documentation process. It's not that hard. I think this can be done by everybody in our group. And we have 6 minutes.
Tom, great talk. Obviously very helpful for those of us that spend time in clinic. We deal with these patients all the time. So just have a comment and a question. In terms of a comment, I certainly understand why trying to get patients to goal remains very challenging. It takes more than our 30-minute appointment, trying to add multiple medications. So sometimes what's old is new again. We all remember 20 years ago when simvastatin was combined with Zetia, and I think because Zetia was expensive at the time, kind of went by the wayside. I think any opportunity to put Vascepa with a statin, put Zetia with a statin again, is going to be helpful, because when you start to talk to patients about adding 2 and 3 just their cholesterol medicines to their 2 and 3 blood pressure medicines, they just don't want to go there, and they won't go there. And so you take what you can get, and they're left with an LDL of 80. My question to you is, 20 plus years ago probably, there were some studies that came out where they were able to raise HDL to like 90 to 100. And it seems like in the clinical outcomes trials, in the end, it did nothing. Is focusing on HDL dead?
Yeah, so that's a really good question. The first part of the question is a very important feature, and that is getting patients on multiple medications is difficult. They get a copay for each one. A lot of people are living on $800 a month, and spending $400 of it is difficult. So I agree with you that that's a very difficult. Mike Miedema may have a comment on this, because he's the one we've been kind of having an exchange about why don't they have some of these combinations. Vytorin is what you were talking about, which is simvastatin and Zetia. And actually, Vytorin isn't even really around anymore. So, Mike, do you have some thoughts around the combo therapy?
Yeah, it's safer and it's more effective, but it is 2 pills versus 1 pill, right? So that's the downside, the polypharmacy part of it. And so there is a push to move rosuvastatin at either 5 or 10 milligrams over the counter. And actually, that's actually being looked at pretty heavily. And then with that, have a combo of rosuvastatin 10 with ezetimibe 10 over the counter as a combo. And so our government should definitely fund that. Like, that would be a very cheap way to treat people's cholesterol. It'd be incredibly effective. Given the way things work, it'll probably be about a decade before it's ready to go. And so that's a direction we should probably move in, but I'm not too optimistic it's going to happen anytime soon.
And then your other question, I think, was around the CETP inhibitors, is what you were talking about. And the CETP inhibitors we were involved in a little bit of that research. The drugs raised HDL dramatically, so everybody thought this is it. By promoting HDL, we're going to see less atherosclerosis, less events. And lo and behold, after hundreds of millions of dollars in research, those drugs were all shut down. And what they did was a couple of things. All HDL is not created equal. So the HDL that was promoted may have not been the helpful HDL, HDL2 or HDL1, as opposed to the helpful one. And number 2, they saw side effects like sodium retention, hypertension. They actually saw an increase in events. Interestingly enough, though, much like I've been watching sort of this development of lipids for years, they did notice that LDL seemed to go down. And so some of these drugs are actually being researched and resurrected in certain fashions as LDL reducing drugs. So we're not done with them quite yet. And I just think it really points out how much is happening in this field. It's really exciting that you just see science and medicine kind of coming together to help us treat our patients. Jay?
Tom, great talk. A couple questions. You see TV ads for coenzyme Q and statin intolerance. Is that just marketing? And then the other question would be, sometimes patients ask about, rumors of statins and dementia.
Oh, good one. In fact, I prepared a slide on statins and dementia, but I won't bore you with it. But to talk about the dementia, actually, if you look at, well, I will show the slide. If you look at dementia, and the risk of statin use and the risk of dementia or Alzheimer's, and systematic review here on meta-analysis, actually most of the trials actually favor the statin therapy. So it's controversial, But I think we can tell people it's unlikely to be, it's not going to cause Alzheimer's. A lot of people are concerned, my parent had Alzheimer's, am I gonna get Alzheimer's from this drug? And I think we can say confidently that's unlikely to be the case. And dementia itself, not Alzheimer's, is a lot of times it's small vessel ischemic disease. By cleaning up the lipid panel, you've sort of cleaned up those small vessels, you can probably prevent. And I think the prevention of dementia was around 7%. The prevention of Alzheimer's was up to 20% in some of these studies. So this is continuing to be looked at, but right now I think we can confidently tell people, no, you don't need to worry about that one. And then the second part of your question was?
Coenzyme Q.
Yeah, coenzyme Q, I don't think it hurt. I mean, a lot of times when people come in with their supplements, say, my answer is, it probably isn't gonna hurt. And it might help. Coenzyme Q, so HMG, what Jay's getting at, HMG-CoA significantly reduces your coenzyme Q. And coenzyme Q is ubiquinone, so ubiquinone everywhere. It's responsible as a cofactor for a lot of processes in the body, including a lot of muscular processes. It's certainly, I do recommend it in my heavy exercisers because I think they're using a lot of ubiquinone. The data isn't, there was a randomized trial that I think gave maybe 100 milligrams once a day, didn't show a clinical benefit, but I'm not, and some people say maybe they didn't give enough. I don't think there's anything to say that it's going to hurt. There's a few studies that say it helps. If people want to take it, they can. I can't recommend that to people and say it's going to necessarily help. Low vitamin D is kind of similar. So patients with low vitamin D, I kind of mentioned it early on there, with vitamin D levels below 20 seem to tolerate their statins worse. And whether supplementing vitamin D does any good, I think there was another larger trial that looked at that and actually it didn't at all. It may have caused a little bit of harm. So it's kind of thing where there are these metabolic effects of these drugs, and then we think we can just take a supplement and make it go away, and that's just not the case. We can't necessarily obviate all the issues it's causing by an over-the-counter supplement. And I tell people, you know, there's remarkable how few people take milk when they get older. You know, it's very important in bone health. It's very important in vitamin D levels. And getting some sun, and getting outside, and getting some, you're probably better off with that than taking a vitamin D supplement or a CoQ enzyme supplement. I don't know, Mike, you got any thoughts on those?
No, I agree. You know, the risk with CoQ10 is zero pretty much, and so you're not going to do yourself any harm by trying it. The one randomized trial didn't show really any benefit, but yeah, I agree. Do you use anti-inflammatory medications at all for people?
So I was very big on antidepressants. In fact, I was going to include it in the talk because there was several trials. We went back to the HSCRP lowering of bempedoic acid, which really was exciting because we know that patients with elevated CRP and inflammation plays a huge role in atherosclerosis. And colchicine, a common gout drug, was studied in 2 trials and was starting to show a very encouraging and interesting benefit that this may be a way to add to treat some of the residual risks that we see after statin therapy. And then the big trial just came out, I'm blanking on the name, where they studied it in a very large number of people and colchicine had no benefit. And it was a bit disappointing. But I don't think the inflammation story is done. We know that inflammation plays a big role. It's a matter of how we attack it, what medications we use. I really thought colchicine was going to make its way into mainstay therapy as being for chronic coronary disease. But based on that trial, I don't think we can recommend it right now. Does anybody remember the name of it just came out?
It wasn't Lodoco, right? That was the.
No,
That was
Lodoco was
good.
positive.
That was positive.
Clear synergy.
Huh?
Clear synergy.
Clear Synergy. Ding, ding, we have a winner. Give him a snow cone. Yeah, that's exactly right. Clear Synergy, it literally just came out like 2 weeks ago. Spironolactone was in that trial, and Clear Synergy was a very large trial looking at chronic atherosclerotic heart disease, elevated CRP, giving colchicine, thought it was going to work, and it had no impact.
Should there be any changes in lipid-lowering therapy in patients after 80, 85 years of age?
Really good question. The side effects we talked about, and some others that we didn't talk about, do increase in elderly patients. One of the reasons that older patients get statin intolerance much more than younger people. I mean, I see FH patients, 18 years old, 20 years old. We start them on high-intensity statin therapy. They almost never get statin intolerance. Whereas an elderly patient, 80-year-old patient, can get it on 10 or 20 milligrams. Why is that? Well, because these medications are going through the liver in certain enzyme pathways, and there are drug-to-drug and drug-to-food interactions. And those interactions, as you get older and your metabolic activity is reduced, you're on more medications, those become more important. So statin intolerance is a much more important issue as you get older. I personally think that that's also the group one way to look at it that can benefit most from statin therapy. You know, they're your highest risk patients for atherosclerotic heart disease. Age is the strongest risk factor for cardiovascular disease. So we have the discussion, how you're feeling, how you're doing on it, everything's good, and I don't think there's a reason to withhold it. If you look at the guidelines though, I mean, I can go back to those guidelines, but if you look, they stop at 75, and after that, you can have a discussion on an individual basis. I'm not in the habit of taking people off life-saving therapy because they reach a certain age.
So you're treating somebody with a high-intensity statin, and then they become a diabetic. They need, you know, some metformin or something like that. Do you switch the medication to bempedoic acid and Zetia?
Yeah, so good question. The reality of that is a lot of people become diabetic that are not on a statin therapy. You know, we've been following A1Cs for years now. People on statins, not on statins. Insulin sensitivity, truncal fat, you know, it comes with age. And one thing is if you do see, though, that somebody's A1C was 5.1 or 5. Let's say it's more like 5.6, so they're sort of borderline, you put them on a statin and it jumps up to 8, you know, and they haven't changed their diet and their weight hasn't changed. I do think you need to be a bit concerned about that. And then adopting some of these strategies we talked about, backing off on the dose, adding non-statin therapy. There's kind of some anecdotal evidence. I can go back. If you look at the cholesterol treatment trials, that maybe Pravachol has a little bit less incidence of diabetes than some of the others, so I might switch them to Pravachol. But you certainly need to be aware of it. Everybody I start on a statin, I want a baseline and then know what happens once we start it. If it's sort of a gradual evolution that looks to be commensurate with their weight gain and something you might expect anyways, I don't think you can blame the statin. So you have to kind of look in detail at what happened in the time sequencing. Yeah, so here, west of Scotland, actually the curve is on the other side that favors statin. Lower odds of diabetes, and that's a Pravachol study. So maybe switch to Pravachol if you think it's that. Start thinking about non-statin therapies.
Yeah, we do have one virtual question thus far. It comes from Dr. Lesser. He says, excellent talk. The question is, how can we expedite patients to be seen in the prevention clinic, specifically with very high triglycerides or very high-risk patients in general?
You can talk to your program director.
We're working on that.
I think that's a problem with MHI and medicine in general. You know, access to our clinics is not just prevention; it's everywhere. You know, we have a lot of irons in the fire. We have a lot of imaging to do. We have a lot of outreach to do, and we certainly need to get confident and work together with our advanced nurse practitioners and our PAs because they're knowledgeable and skilled, and get people comfortable with seeing them. That helps with access. Turn patients back over to their primary care physician, you know, once they're stable and there's not adjustments happening, so that opens us up to new patients. A lot of strategies, hiring new qualified people, but that's a problem across the system, not just the preventive clinic. I mean, I'm seeing weights in EP, I see weights in heart failure, in all the clinics.
Thank you.
Thanks very much.